Good afternoon, everyone. We'll give everyone just a couple minutes to get back from lunch before we'll jump into our second breakout session.
Hey, Aaron, do you want me to go ahead and start sharing my screen to get my PowerPoint all loaded up?
You can absolutely do that. Let's make sure it all works and is good to go.
All right. All right, you able to see that okay?
Perfect. And we are at, yep, we can see it, and we are at noon. So we will go ahead and get started here while there's still a couple folks joining from the main room. So I'm going to take a moment to introduce Dr. Swazo. So welcome, first off. Thank you for joining us today. Dr. Swazo is a current third-year Chief Pulmonary and Critical Care Fellow at Indiana University. His focus is clinical time at IU within the field of severe clinical asthma and medical education by participating in the clinician educator track, as well as concentrating on healthcare disparities and how this gap can be bridged in our local community. Dr. Swazo went to medical school at Ross University, followed by residency and a chief resident year at internal medicine at the University of Arizona in Tucson, ultimately leading to him to his fellowship at IU. So welcome, Dr. Swazo, and I will hand it over to you to begin your presentation. Thank you so much.
All right, sounds good. Thank you so much. I appreciate it. And thanks again for the opportunity to be here. This is going to be a true crash course in a lot of really big topics that we're going to try to get through in as much detail as possible. Obviously, we only have half an hour, so going to try to get through a lot of information. We're going to get to know a little bit of everything. We're not going to be a master of anything, essentially, with as little time as we have, but we're going to try to learn as much as we can, I guess, in this presentation. So I don't have any conflict of interest. If you know of anyone that's willing to pay me to do lectures like this, by all means, I'm a broke third-year fellow, so anything would be useful. So the way that we're going to try to approach this a little bit is we're going to kind of give you a little bit of a case discussion. Patient that I saw recently in one of our hospitals, and then we're going to try to do a little bit of comparison in terms of the pathogenesis between asthma and COVID. You've already gotten a whole bunch of kind of basic information from some of the other lectures earlier today, so I won't go into a whole lot of detail. We'll briefly talk about some of the therapeutics for each of the pertinent diseases, and then we'll talk as much as we can about vaccines and try to focus on as much time as we can on those. And briefly kind of how we should approach some of our conversations with our patients, and hopefully have some time at the end for questions and discussions. All right, so let's go ahead and get into one of the case discussions that we'll present for today. So patient that I saw fairly recently this last month is a 33-year-old young African-American lady, unvaccinated for COVID-19. She has a severe history of persistent eosinophilic phenotypic asthma on Dupixent or dupilumab. And she's been on that for about the last 5 or 6 months. Unfortunately, hadn't been taking it the last 2 months. And she had been to the hospital twice in the last 2 months for an asthma exacerbation. So this time she came to the hospital for shortness of breath, some coughing, some dyspnea on exertion, and wheezing for the last few days. She'd had known COVID close contacts, including her husband and her son, and which her son was 8 years of age. Both of them were obviously COVID positive, neither of which were vaccinated. The son obviously by way of age, and the husband just by choice. She came to the hospital. She was tachycardic, tachypnic, normotensive. She was febrile, and she was pretty significantly hypoxemic on arrival, to 78% on room air. Obviously, she doesn't use oxygen at baseline. So the ER put her on a non-rebreather at 100%, and then obviously they got some basic workup. So our initial imaging, and for those of you that have been around COVID this last year and a half, this looks like a classic case of terrible COVID. So you see these diffuse bilateral pulmonary infiltrates that are very dense and obviously contributing to her severe hypoxemia. And this is about the time when you start thinking, things are starting to burn down. This is a really terrible chest x-ray for someone that's just coming in acutely, otherwise very young, right? So you start thinking about how severe this could possibly be. So you start getting a little bit more workup, in which you notice that she has some pretty significantly elevated inflammatory markers. She has some lymphopenia, a little bit of an AKI, and some mild transaminitis. Again, very classic for someone with pretty severe COVID. So jumping through the hospital course a little bit, and obviously she was found out to have COVID positive. They initially tried her on Vapotherm or heated high flow nasal cannula. This failed fairly quickly. They weren't able to get her oxygen up above 82%. They tried her on BiPAP or non-invasive ventilation, which also failed and weren't able to get her up above 85%. So that's when they called us in ICU for admission. So once again, we weren't able to oxygenate her well using BiPAP. So ultimately we intubated her and put her on mechanical ventilation. Despite this, we still had very severe difficulty with oxygenating the patient despite mechanical ventilation. We tried all sorts of higher, evidence of mechanical ventilation, including pressure control. We tried inverse ratio ventilation, kind of more advanced modes of mechanical ventilation. Despite that, we couldn't oxygenate her. Ultimately, within that same day, we ended up having issues with ventilation. So now we were dealing with an oxygenation issue and a ventilation issue. So we ended up calling our ECMO colleagues over at Methodist, where that same afternoon, she was ultimately transferred over there. They were cannulated, and then she was started on VV ECMO. That's a whole separate lecture in and of itself, but obviously this is a very critically ill patient, to say the least. So let's kind of jump into kind of why this is clinically important and why the distinction between these two very distinct disease processes are clinically relevant in our practice. So jumping into asthma, right, as some of the other guest lecturers already kind of discussed, asthma is a chronic disorder of the airways, right? So it leads to a lot of chronic inflammation, where you have different phenotypes in which some folks have more of a neutrophilic predominance or eosinophilic predominance. Ultimately, this leads to more mast cell activation and causes that epithelial cell injury, right? So I don't know how well you guys can see this, but there's a lot of different factors that are involved, and which is why more of these personalized medications for asthma are being used based off of the interleukin pathway that's activated when it comes to asthma. At the end of the day, what this leads to is issues with mucosal edema, bronchial obstruction, as well as pretty significant evidence of remodeling thereafter in the chronic setting. As opposed to COVID or SARS-CoV-2, where you have this significant viral replication that leads to ultimately invasion in the type 2 pneumocytes via the ACE2 receptor. And this leads to this terrible inflammatory cascade of all these cytokines just kind of brewing. Specifically, the most common one that we'll see is IL-6, which is why we focus on that one when it comes to the therapeutics, which we'll talk about briefly. And ultimately, this leads to that cytokine storm that we've all heard about. And based off of two different pathways, this will lead to, at the end of the day, leads to this inflammatory disorder, or ARDS, acute respiratory distress syndrome, by way of diffuse alveolar damage. So the clinical dilemma that we get into with these two very distinct diseases is asthma, at least in the critical illness setting, leads to very severe difficulty with ventilation, versus COVID leads to very severe difficulty with oxygenation. So this is a perfect scenario for someone that has to have really, really poor outcomes in critically ill patients. And this is what we deal with, unfortunately, in our ICUs as of late. So the reason that I wanted to bring this up is because obviously this leads to significant morbidity and mortality in our patient population. And what needs to be done is controlling the asthma to help prevent these critical disease processes from developing, right? So there was actually a recent study just a couple of weeks ago that was published in the Journal of Allergy and Clinical Immunology, and then kind of spread out through CHEST and ATS. So what they ended up noticing is that those patients with asthma who had required clinical care, specifically either ER settings or inpatient settings, within the last 12 months, prior to getting COVID, ultimately ended up having increased risk for severe COVID outcomes. And this makes sense. You know, everyone always kind of thought that anyone that had underlying lung diseases would have worsening clinical scenarios when it comes to underlying COVID, right? And this kind of proved some of that in that sense. So what they ended up noticing is that proper medication treatment for asthma obviously would lower this risk. So at the end of the day, controlling your underlying asthma will help in turn prevent you from having a more severe critical illness when it comes to COVID-19. So as we've heard and we've known for this last year and a half or so, those that have the most high risk factors for severe COVID infection are those with certain underlying medical comorbidities, specifically cancer, chronic lung diseases, COPD, asthma, pulmonary hypertension, cystic fibrosis, et cetera, but also those with metabolic syndrome, type 2 diabetes, et cetera, obesity, smokers, and obviously transplant patients by way of their immunosuppression. So what this means is that the overarching theme, and we've heard this over and over, is that those with severe underlying comorbid conditions or immunocompromised patients will have the worst outcomes when it comes to superimposed COVID infection, right? So the concern is that a lot of our asthmatics, especially those with severe persistent clinical asthma, have numerous comorbidities, most commonly metabolic syndrome, right? A lot of them have underlying obesity, diabetes, and if they're on oral corticosteroids, especially at higher doses, they're functionally immunosuppressed, right? So this leads to a very distinct scenario in which it's just a recipe for disaster when it comes to severe critical illness when it comes to COVID superinfection. So that being said, how do we treat and how do we prevent some of this stuff, right? So the treatment for asthma could potentially be a double-edged sword. And Dr. Klepper did a great job of kind of talking about the GINA guidelines and the step-up therapy and whatnot. And the only part that I'm going to kind of focus on is the very severe or uncontrolled asthmatics kind of in the step 5 region, right? So these are those folks that are on the highest dose of inhaled corticosteroids and LABA combination, and they're being assessed and possibly already on these injectable medications for phenotypic asthma, right? Whether it's anti-IgE, IL-5, or IL-4 injectables. But on top of that, some of them, or a lot of them at this point, could also be on oral corticosteroids, which in turn would cause some form of immunosuppression, right? So what I wanted to chat about, I guess, and at least bring up, and I believe Dr. Gaston's going to talk about this in a lot more detail later, is we do have obviously some of these injectable medications that are coming more into clinical practice that we're seeing more often, such as dupilumab and IL-4 receptor antagonists. You'll have mepolizumab and omalizumab, which are probably the 3 most common that you'll see in the outpatient setting, and they've worked wonders for a lot of our patients. Especially when it comes to trying to get them off of the oral corticosteroids. So they do work great for those severe persistent clinical asthma patients. Contrary to that, we have our SARS-CoV-2 treatments, which, spoiler alert, there's not a whole lot of treatments that actually are working in terms of the inpatient clinical setting. So we have a lot of information as to what doesn't work, and kind of briefly going over some of those. We all remember hydroxychloroquine in the beginning, and all the IDSA guidelines tell us against the use of hydroxychloroquine, especially in the inpatient setting. That's based off of randomized clinical trials and non-randomized clinical trials in conjunction. The issue with it is that it actually led to higher likelihood of being put on the ventilator, in addition to other side effects such as QT prolongation. It would have been fantastic because it's super cheap. It's only $15 for a 10-day supply when it comes to oral tablets. So that would have been great if it worked, but all of the data that we have suggests that it does not, and it should not be used. And then we said, well, if that doesn't work, why not a combination of hydroxychloroquine and azithromycin? Ultimately, once again, the IDSA, or the Infectious Disease Society of America, basically said that it does not work, and that's based off of other clinical trials as well, had no benefit in terms of morbidity, mortality, or hospitalization time. So on the contrary, it actually had increased risk of QT prolongation as well, which ultimately led to patients having torsades and VTAC. Once again, it would have been fantastic. In combination, these two medications are only about $25 for a 10-day supply, which would have been great. But once again, all the guidelines say that it does not work in the clinical setting and actually causes more side effects than anything. And then lastly, we heard a whole lot about convalescent plasma. Ultimately, the IDSA guidelines say that you should only use this in the context of a clinical trial. All the data that we have as of right now showed no significant beneficial effect on mortality. And ultimately, it's a very expensive medication without any significant benefits as of right now. And obviously there are side effects in conjunction with that. It is essentially a blood transfusion, so there's a risk of associated lung injuries or cardiopulmonary overload. So a lot of side effects with not much potential benefit, and it's extraordinarily expensive, about $3,000 per unit of CP that's given, with not much data for improvement in terms of mortality and morbidity. So what does seem to work, at least in the inpatient setting, right? Dexamethasone is probably our greatest go-to medication as of right now, and this truly depends on the severity of the patient. What it has been studied and what it does have mortality benefits is in those that are severe or critically ill. And this has actually improved not only the mortality, but also had less patients on the ventilator ultimately. And it's very cheap, especially in the oral tablet standpoint. It's about $6 for a 10-day supply. So it works and it's cheap. So this is a great combination of things to use, right? What else seems to work is remdesivir. Again, this also depends on the severity of the patient. So in those that are non-severe, likely doesn't have a whole lot of use, but in those that are severe but not quite critically ill, it does seem to have evidence in terms of reduction in mortality. But it is also very expensive. It's about $5,000 for a treatment course for 5 days, essentially. So, but at the end of the day, if it seems to work and has improvement in terms of mortality, I think it's worth it, right? And last but not least is tocilizumab, or one of our anti-IL-6 inhibitors, and this acts on that pathway that we mentioned when it comes to that cytokine storm for COVID. So tocilizumab does seem to work in those that are critically ill, and it does seem to have lower mortality in those patients. That being said, there is also quite a bit of side effects, including increased risk for superimposed infections, such as bacterial, fungal, or mycobacterial infections. So it does have to be used kind of with quite a bit of thought and concern to make sure you rule out other infectious causes. And it is very expensive as well. It costs about $20,000 for a one-time supply. But at the end of the day, if it improves mortality, I think it's worth it, right? So I mentioned, we don't really have a lot of great treatment, right? But that's kind of a lie. The best treatment that we've found right now is prevention, right? And that's over and over, we've seemed to have found this. So as of right now, the best thing that we can do to help prevent you from getting COVID is vaccinations, right? And this does seem to be extraordinarily efficacious. And let's go into some of the details behind this. We have a few different vaccines that are available currently, and we're only going to go into the ones that are being used for emergency use authorization, and now that we finally have one that's FDA approved. So we're only going to talk about the replication incompetent vector vaccine, which is the Johnson & Johnson, and then the 2 mRNA vaccines, which is our Pfizer and Moderna, right? So let's first talk about the replication incompetent vaccine. So essentially what this does is that it uses a different vector virus. Most of the time it uses adenoviruses, which are engineered essentially to not replicate inside of the cell. All it does is express that viral protein, which in our case, what we wanted to use was that spike protein that's used for COVID to help us detect it. And essentially what this does is that it creates that immunogenic response to help, once the body finally sees the actual virus, it visualizes the spike protein and then creates immunity, or essentially fights off that virus as a result of that. So the drawback to these vector vaccines is that if your body has been exposed to that vector that's used for the actual vaccine, then pre-existing immunity to the vector might not allow you to create a very good immune response essentially to the vaccine. So this is our Johnson & Johnson vaccine, as we all know, our kind of one-time dosing medication, as opposed to our mRNA vaccines, which was actually the first vaccines that were produced for COVID. This was an entirely new approach, but I reiterate that this has been around for almost 2 decades, this technology. It's just the first time that it's been used towards a vaccine approach. So essentially what they do is that they administer the vaccine, they administer this RNA that's translated into the target protein, which once again is that spike protein that we're trying to visualize. And this in turn elicits that immune response. So this is the spike protein here that essentially goes into the human cell, and it enters the cytoplasm but doesn't go into the nucleus. So once again, this does not interact with your DNA. And that's really important, I guess, for our patient population. So the drawback to these is that they do have to be stored at very low temperatures, which obviously makes it difficult for some folks in some places when it comes to storage, and in turn for immunizing, I guess, the general population. But there are workarounds around that are kind of being implemented. So once again, I reiterate, this does not alter your DNA, it never enters the cell nucleus, and doesn't affect anything. It just kind of replicates to create that protein that we're trying to mimic. So into a little bit more detail about each of these. So the Johnson & Johnson uses that adenovirus 26 vector to express that spike protein. It's a one-time single dose, and it is actually being evaluated as a 2-dose regimen, and it's currently authorized for use in the US as a emergency use authorization. In terms of the efficacy, and again, we're only going to be looking at the clinical trial data, and we'll talk a little bit about the variants that are of concern. So in their phase 3 trial, this showed an almost 70% efficacy at preventing moderate and severely critically ill COVID after 14 days following the vaccination. So this was based off of 40,000 participants, in which of those 40,000, 464 of them ended up getting moderate to severely critically ill COVID. 116 of them were in the vaccine group and 348 in the placebo group. So what's important to know is that those that were severe or critically ill, that efficacy actually improved after 14 and 28 days, meaning that your immune response seemed greater thereafter. So it is important to note that that 14 and 28 day marker is important when it comes to your immune response, right? In terms of side effects and safety profile, it's extraordinarily safe, and you'll see this kind of throughout the other vaccines as well. Minimal side effects, headache, myalgias, fevers, and site pain, injection site pain. And these side effects were more severe in the younger the patients, obviously, because you're able to create a more immunogenic or a more robust immune response, right? So weighing the side effects and the safety profile, by all means, I'd rather have some fevers, fatigues, and myalgias than have COVID, where you don't have a lot of good therapeutics for, right? So let's diving into the Pfizer and the Moderna vaccines. So starting with the Pfizer, that's that mRNA vaccine that we talked about. It's given intramuscularly in a couple doses a few weeks apart. Now, obviously, these slides need some updating based off of the FDA approvals for some of these mRNA vaccines. Everything changes day to day and week by week here. So looking at the efficacy for Pfizer, though, in the initial phase 3 trial, it showed a 95% efficacy when it comes to preventing symptomatic COVID after the second dose, when you've assumed that you have your full immune response, right? This is based off of 36,000 participants, 170 confirmed cases, in which 8 of them were in the vaccine group and 162 in the placebo group. Of the 10 severe cases that were noted, 9 of them were in the placebo group. So it's extraordinarily efficacious at preventing severe and critically ill COVID cases, right? And what about the safety profile? Again, very similar to the Johnson & Johnson vaccine, more so after the second dose, which is when you have already created some sort of immune response, and now you're kind of fulfilling that and making it more robust, right? So injection site pain is going to be your most common thing. Once again, more common in the younger patient population that can produce that robust immune response. And the initial concern with the Pfizer vaccine was anaphylaxis, and this was noted at a rate about 5 per million doses of vaccine. In the first 10 million doses, we saw 50 episodes of anaphylaxis. That being said, we have great treatment for anaphylaxis. We don't necessarily have great treatment for COVID, right? So it's risky in some ways if you've had a history of anaphylaxis, and we'll kind of go into that more in a few slides here. What about the Moderna vaccine? Again, this was actually the first one to be produced when it comes to the COVID vaccine response. And surprisingly, after the genome for COVID was actually found within 2 months of publication, this vaccine was already in the arms of folks, and they were starting their phase 3 clinical trial. So extraordinarily impressive. Similarly, it's given intramuscularly in a couple doses 4 weeks apart, and it's again authorized for use in the US and the EU. In terms of efficacy, again, very similar to the Pfizer vaccine, extraordinarily efficacious. And when you look at the numbers of the 30,000 participants, 196 confirmed cases of COVID, 11 in the vaccine group, and 185 of those in the placebo group. Of those 185 that were found, 30 of them were severe cases, all of them in the placebo group. So again, very efficacious at preventing severe or critical illness when it comes to COVID. What about the safety and side effect profiles? Again, very similar to the Pfizer vaccine, right? Injection site pain, some fatigue, some myalgias, some fevers, et cetera. Once again, more robust in the younger patient population, and slightly decreased when it comes to the anaphylaxis risk. So of the first 7.5 million doses of vaccine that were produced or that were given, 21 episodes of anaphylaxis. Once again, it's treatable, it's preventable, and there are ways to kind of make sure that you minimize that risk for folks, which we'll talk about here in a moment. So diving into some of the special patient populations that we should be aware of, how do we approach our immunocompromised individuals? And the issue with those that are immunocompromised, specifically our transplant patients or our cancer and chemotherapy patients, the immunogenicity or that immunogenic response that you produce after the vaccination is attenuated, it's lower, right? So this becomes an issue because they may not even produce an immune response in response to being vaccinated, even after 2 doses, right? So these folks, even if they're fully vaccinated, should continue to use kind of those personal measures, minimizing exposures, hand hygiene, using the mask as much as possible, even after they're fully vaccinated. And you've heard in the news that there's been a 3rd dose or a booster vaccine that's been approved for those immunocompromised individuals. Now, this is kind of a misnomer because usually you talk about booster vaccines, it's assuming that you've already created an immune response. So the argument is actually that even after 2 doses, these folks don't even have an immune response. So that shouldn't actually be called a booster. It should quite literally just be called a 3rd dose for them in order to try to create an immune response when they actually are exposed to COVID. And there's more and more data coming out that likely in September at some point, they're going to be approving for a booster dose, a true booster for the general population, for those that have been vaccinated for at least 8 months or longer after the 2nd dose. And we'll probably be seeing that or hearing something about that in the next couple of weeks, I would imagine. So who shouldn't get vaccinated? There's not that many exceptions. If you've had allergic reactions to the previous vaccines or their components, which I'll mention here, then you probably should at least be very aware, or maybe you shouldn't be vaccinated, right? And true anaphylaxis, not that common, right? If you've had some sort of immediate allergic reaction within hours of receiving the vaccine, then you should probably be more aware. But if it's been more than 4 hours post-vaccine, it's likely not a response to the vaccine itself, or maybe some other environmental exposure, right? So those people that say that they're allergic to the vaccine or the components of the vaccine. So in mRNA vaccines, the only other component that's in there is a polyethylene glycol, which is actually just a food additive that's found in a lot of different foods, and it really just helps maintain their moisture and consistency to certain foods. It's found in soups, salad dressing, baking mixes, biscuits, cupcakes, pancakes, teas, cheese, macaroni. I mean, it's in a ton of stuff. So unless their diet is extraordinarily limited, I doubt they're actually allergic to any of the vaccine components in the mRNA vaccines. So what about the Johnson & Johnson vaccine component? In this case, it's something called polysorbate, which is another food additive. It's actually an emulsifying agent that's basically, if you think of oil and water, so this allows incompatible substances in food to kind of stick together. So certain food products like ice cream, frozen custard, sherbets, whipped toppings, other frozen desserts. So if they're not eating any of that stuff because they're allergic to it, maybe you should consider, I've never heard of people being allergic to any of these things, but something to be aware of at least and have that conversation. So the last few slides kind of focusing on some of these variants of interest versus the variants of concern. And there is a distinction between the two. So going into the variants of interest, the one that's been identified more recently is in June, which is the Lambda variant, found in Peru, identified in Peru originally in December of 2020, hasn't really been significant enough to create more immune response or attenuation when it comes to our vaccines, but something that we might hear about more in the future. And then we've all heard a lot about our variants of concern, specifically being the Delta virus, right, or the Delta variant. So this was actually first found in December of 2020 in India, and it's now actually the most prevalent strain in the US and the UK. And the issue with it is that it's more transmissible as a result of the spike protein mutations, essentially. And it creates higher viral loads when it comes to the infected population, which is why we're seeing younger and younger patients that are more critically ill, more acutely, and becoming more critically or more quickly. So the issue has become that some of the vaccine effectiveness is slightly decreased as a result of this, but still I've yet to see one normal patient that is not immunosuppressed, whether from cancer or transplant. So one general population patient that is vaccinated and critically ill. I've yet to see that. I've seen a lot of patients that are transplant patients that have gotten vaccinated, or cancer patients that have gotten vaccinated and become critically ill. But again, that's probably because they didn't develop an immune response to begin with. So last but not least, and we've heard a lot about this, vaccine hesitancy. So this is a major issue, right, when it comes to achieving that vaccination coverage that's broad enough to help reduce our transmissibility and our infectious rates in the general population. If you look back, actually, the World Health Organization actually cited this as a top 10 global health threat back in 2019, and it's never been more true than it is now, right? There's just creates so much misinformation as a result of this that it becomes tougher and tougher. So this is kind of how I feel after hearing all these arguments, and without going into every single thing that we hear on the internet or on social media or in our offices, we hear this all the time, right? And there's answers to all of this. So it truly just takes time and effort to try to have these conversations with our patients to try to help them understand, what we're trying to achieve and the safety and profile of these vaccines, and hopefully that'll allow us to reach the turning point that we need to be able to get these patients vaccinated and prevent severe critical cases of COVID, right? So hopefully, I've answered some questions. Quick brief update on our patient, unfortunately, is even since the last time I updated these slides when I submitted them last week, some things have changed. She was on ECMO for about 3 weeks, and as of Monday, unfortunately, she has since passed away. Extraordinarily young patient that could have probably been prevented. Her husband has since been discharged from Eskenazi, actually on Tuesday. He's on 6 liters nasal cannula quite a bit, and their child at least is safe at home with him. But I argue that this could have been a preventable death had we controlled her asthma better. And had we been able to vaccinate her, I think we could have probably prevented this unfortunate death. But hopefully we have a few minutes for questions. I'm here to answer anything if I can. I don't know if I missed anything in the chat, but thank you guys for listening. I appreciate you.
Thank you so much. Looks like we have one question in the chat from Dan. Does helium-oxygen mixture have a role in treatment for hypoxemia in COVID-related asthma exacerbation?
It's a great question. So Heliox, for those that you don't know, is a combination of 70% oxygen, 30% helium. It tends to work more so in patients that are suffering from obstructions, which are true obstruction, meaning some sort of mass in the airway that we're trying to bypass, not so much from COVID. So it does help when it comes to pure asthma exacerbations, because we can bypass some of that severe obstruction that's occurring, but not so much for COVID, since there's no true obstruction. It's truly just lung injury, essentially. So what we have had some benefit from is INO therapy or prostaglandin therapy. So those do seem to help in terms of improving our PaO2 or our oxygen delivery. No mortality benefits, but it does buy time essentially to try to help get them to ECMO if they're appropriate candidates. It's a good question though.
Tisha asks, examples of when a person would have preimmunity with J&J vaccine.
Examples of when a patient would have preimmunity.
So I think the question is around when you mentioned the Johnson & Johnson vaccine, sometimes they might not have an immune response.
I see what you mean. So an example would be if someone, so adenoviruses are just another common cold essentially. So if you've been exposed to a specific strain of the common cold, specifically adenovirus 26 strain, which is the one that they use for the Johnson & Johnson vaccine, that you might not create as much of an immune response because your body's already seen the strain that's trying to expose you to create an immune response against COVID. They specifically use strains of viruses that are more rare and are not seen in the general community as a result to try to help prevent that. But again, it is in theory possible, which might be one of the reasons as to why the efficacy of the Johnson & Johnson vaccine is not quite as robust as it is with the mRNA vaccines. It's a great question.
I have a question myself. I am all about vaccine hesitancy and curious about, as a provider, what your strategies are with talking to hesitant populations. What communication strategies are you seeing that are working, what isn't working, and maybe specific examples of asthma populations where you've had to have those talks.
Yeah, it's a great question, Aaron. I think the most important key is patience and time. So it truly is, having those conversations, showing the data and trying to not be biased. And it's very easy to show bias in those, scenarios, right? So I have certain documents that I've printed off and I keep in my outpatient clinic that show the efficacy of the vaccine, that shows the side effects of the vaccines, and kind of compares it to other vaccine trials that we've done in the past. There aren't very many trials that, when it comes to vaccines, that have this many patients enrolled in such a short period of time. That's a direct result of the pandemic, obviously. So we have thousands and now millions of doses that have been produced and given to patients. And so we have a great idea of what the safety profile is for these vaccines. So truly time and patience essentially is what I do, and try to give them as much information as I can. And then when it comes to, I guess, asthma, obviously we're well aware that there's a lot of social disparities and social determinants of health when it comes to asthma, and that it disproportionately affects certain demographics of patients, in which there is more vaccine hesitancy in certain demographics of patients as well. So that becomes kind of multiple conversations at once, is trying to break down those social determinants of health and those barriers when it comes to mistrust in the medical community, while at the same time trying to give the information about the vaccine. So these aren't conversations that happen in one sitting. These are conversations that happen in multiple visits, and I think that's the challenge that we have to try to challenge ourselves, I guess, or try to accept and kind of move forward from there.
Great. Thank you. Does anyone else have any other questions at this time for Dr. Swazo? And feel free to put them in the chat or unmute and ask them.
Yeah.
Looks like Tisha says, to your knowledge, is there any effort to contact asthmatic patients to assess condition and medication compliance?
Yeah, and this truly kind of depends on institutions, and it varies by institution. So one of the things that we're trying to promote at IU, especially in the adult population, is trying to establish a severe clinical asthma clinic, essentially, because it requires a lot more resources, right? And part of that is someone that can reach out to the patients, especially those that have a history of more severe clinical asthma, to go over, triggers, to go over use of inhalers, to talk about adherence, right? And that just takes time, and it takes power, right? Manpower, woman power, right? It takes people to be able to do that. So the more resources that you can provide in your clinic will allow you to do things like that, which is to contact those asthmatics, make sure that they're using their inhalers appropriately, see if they need refills, and as opposed to waiting for them to run out, and obviously then they end up in the hospital, right? So those resources are important, and I think it varies quite a bit depending on the institution. Something that we're actively working on here at IU.
Looks like Dan says, will the COVID booster be the same dose as either the initial or second vaccine dose we received in the beginning?
So as of right now, all the data that we show, that we see, or in this new booster that's going to be given, is the same kind of vaccine. It hasn't been modified as of yet. What's great about the mRNA vaccines is that they can be tweaked. For example, if there is a genetic mutation in the virus that triggers a significant difference, I guess, in terms of vaccine efficacy, then they can be modified quite quickly and essentially redistributed. So as of right now, Dan, all the information that we have is that it's going to be the same vaccine, just to try to robust that immune response that we have, essentially to try to increase that immune response that we're already getting.
So another question I have is around adolescents. Now that schools are back in session, there's a conversation about masks being in schools. Are you seeing a lot more admissions now, or are you seeing more problems with asthmatics because of COVID? Children are contracting COVID. What are you seeing in the adolescent population?
Yeah, so I'm an adult, I guess, pulmonary and critical care physician. So I deal with those that are 18 and over, but obviously it's a small world in kind of academia. So the children's hospitals are filling up quite a bit with more and more cases of COVID. The ERs are completely packed. And actually, as of today, Eskenazi is going to be going on a different form of diversion. They're stopping all their elective cases again when it comes to surgical cases, as a result of our ICU filling up with critical cases of COVID, and unfortunately, they're getting younger and younger. The cases that we're seeing are more so in the 30s and 40s population, as opposed to kind of the first and second waves that we were seeing a lot in the elderly or more immunocompromised patients. Now those assumingly have gotten their vaccines, so we're seeing them less and less, but our young patients that otherwise generally have a pretty good immune system are getting sick, and they're unfortunately not great outcomes. We don't have a lot of treatment options, obviously, so this is something that we got to try to prevent.
Thank you. We are at 12:39. So this session ends at 12:40. So I'm going to put some links in the chat for everyone's next session. Dr. Swazo has just put his email in the chat for everyone. So if you have any questions, need to follow up, feel free to follow up with him. Links are going to be in the chat for the next sessions, and you can feel free to head over there. Once again, I want to thank you, Dr. Swazo, for a wonderful presentation.
Absolutely.
Thank you for the hard work that you've done in the last year and a half. We greatly appreciate it. And fingers crossed we're, going to get over the hump eventually. So,
I hope so. Thank you guys. Appreciate you.